Good evening. April is National Minority Health Month, a time to raise awareness about health disparities that disproportionately affect diverse populations. Disease burdens such as sickle cell disease, which is the most common genetic disorder in the U.S., remain higher among communities of color. So it's also a time to encourage action through access to care, health education, and management of disease complications by learning how we all can help make a difference. Hi, I'm Tiffany Taylor, Communication Specialist with the American Red Cross. Welcome to our Facebook Live partnership with blackdoctor.org, where we will explore misconceptions of sickle cell disease and its impact on the Black community. Joining us to help elevate this conversation is Dr. Marjorie DeJoie Brewer, a sickle cell warrior, medical director for the Sickle Cell Association of Delaware, medical director of hemoglobinopathies and global medical affairs, global strategist at Vertex Pharmaceuticals, co-chair of the Mental Health and Wellness Initiative for the Sickle Cell Consortium, and the owner of MadFit, a medical consulting and wellness and health business. We also have with us Dr. Yvette Miller, who is the Executive Medical Officer for the Red Cross Donor and Client Support Center in Charlotte, North Carolina, where she oversees donor eligibility, blood product management, and donor management for 36 blood services regions. Her areas of interest include promoting diversity in the blood supply, increasing donor recruitment and retention in the Black community to support the transfusion needs of patients with sickle cell disease. Next, we have with us Lyric Porter, a sickle cell warrior who has received hundreds of blood transfusions throughout her life, yet has continued to fearlessly pursue her dream of becoming a journalist. Most recently, Lyric has partnered with WebMD to create a supportive Facebook community for patients and families affected by sickle cell disease. As a journalist, she aims to inspire and encourage fellow sickle cell warriors by providing helpful resources and a safe space to discuss topics impacting both warriors and advocates. We also have with us tonight Dr. Lemitra Scott, who is the founder and CEO of the nonprofit organization Breaking the Sickle Cell Cycle Foundation Incorporated, which focuses on promoting community awareness, education, and prevention of sickle cell disease. Dr. Scott is also a pharmacy consultant and mother of a child with sickle cell disease, and she is currently the director of pharmacy for the Tennessee Department of Correction. Welcome to the panel, ladies. We are both honored and excited to have each of you with us tonight. And for those of you tuning in, we want to hear from you as well. So feel free to let us know where you're joining us from. And if you have any questions for our panelists, feel free to drop them in the comments for our panelists to address during our Q&A portion. Well, let's kick this off. Dr. Miller, you work directly with the Red Cross and its Sickle Cell Initiative. The goal for this initiative is to increase blood donations in the Black community to provide closely compatible blood for patients with sickle cell disease. Is sickle cell a Black problem?
Thank you so much, Tiffany, for hosting this event this evening. And sickle cell disease is not a Black problem. Sickle cell disease can be inherited by anyone of any race or ethnicity. But in the United States, the great majority of individuals that have sickle cell disease are African American or of African descent. So we focus on sickle cell disease in the Black community in this country because as African Americans, we have some unique structures on our red blood cells that are inherited. And in order for patients with sickle cell disease, in many cases, to receive the most compatible unit of blood, it comes from someone that is African American or of African descent.
Well, thank you so much for clarifying that sickle cell is not just a Black disease, that it can affect anyone of any race and ethnicity. And if that's the case, Dr. Miller, I have to ask you, why are blood donors who are Black needed?
So blood donors that are Black are needed because, just as I mentioned, in this country, the great majority of individuals that have sickle cell disease are of African descent. And so those Antigens or structures on our red blood cells must be closely matched between the donor and the recipient. Only about 3% of the blood donated in this country is donated by individuals that are African American. So we are in constant need of blood to be donated by individuals of African descent to meet the transfusion needs of patients with sickle cell disease. 1 in 3 African Americans is a match for a patient with sickle cell disease.
Wow. Can you say that one more time? I want to
Yeah.
make sure that we hear that as a community. How many donors who are Black or African American are a match for patients with sickle cell disease?
Absolutely. This is a critical statistic.
Yes.
1 in 3 African Americans is a match for a patient with sickle cell disease, and only about 3% of the blood donors in this country are African American or Black.
Yeah. And I would
So
add one point to that, actually, Dr. Miller, that an average patient in a year requires donations from about 130 individuals. And optimally, because we're talking about compatibility, individuals from our own descent. So I myself, as a blood recipient, I need 180 people. And 1 in 3 match. And only 3% of those individuals are donating for me to get an optimal, compatible match for blood donation. It is so important.
Yeah.
Cannot underscore that.
And she is just one individual, so you can see how quickly it adds up as to how many blood donations we need in a single year to meet the transfusion needs of this largely Black population of patients.
wow, that's incredible. Thank you both for sharing that and really putting it into perspective for us. Lyric, you are a sickle cell warrior as well as an advocate who truly understands firsthand how this disease affects lives. When were you diagnosed with sickle cell disease and how has it impacted your life?
Thank you, Tiffany. So I was actually diagnosed with sickle cell disease via newborn screening. And after I was born, I got screened for the trait as well as the disease. And then the results came back stating that I had hemoglobin SS, sickle cell anemia. And from then on, just throughout my childhood and primarily most of my adolescent and adult years, it's just been a very tumultuous issue for me just because I was affected by it frequently. I've had many hospitalizations, I've had many pain crises, and I've had many instances where I've needed um, blood transfusions. So, I am definitely a person that believes in the importance of individuals who are a part of my demographic donating their blood, for blood product uses because I was at a point where I needed them monthly. So I definitely would appreciate if more people donated blood.
Thank you so much for sharing that, Lyric. That also puts it in greater perspective for us as well. You said at one point in time you needed blood donations monthly. Can you kind of give us an estimate in terms of monthly? How many actual blood products or units did you need when you were going in monthly for those transfusions?
Yes. So I've had two instances where I was placed on protocol blood transfusions. The first instance was during my puberty years. So I would say from junior high all the way to maybe my junior year in high school. I was requiring at least 1 to 2 units monthly just to stabilize my hemoglobin and try to decrease the amount of pain crises that I was having at such a frequent rate. And then as I got older and I started looking into clinical trials, that's when I began getting blood exchange transfusions, and I received those monthly. And with each one of those treatments, I needed at least 7 units of blood each time. So it would definitely take a while for me to get cross typed and matched when requiring 7 units of blood. And oftentimes, I would have to, be at the hospital all day just waiting uh, for the blood to come up to the floor, and for them to go through all of the confirmation procedures to make sure that the blood was matched to me correctly, and go over what each specific bag's donor's blood type was. And so I think that all of that could be cut in time if they had more people donating blood, because they would have a larger supply of the units that they are pulling from.
I agree with you 100%, Lyric. I had the opportunity last week to spend some time in our immuno reference lab last week. We call it the IRL, where we have a team of individuals who spend each day trying to right type match blood products for patients. And so you're right. It's a very tedious, in a sense, process of making sure that that blood is safe and that it will be compatible for the patient. So you bring up a great point. Dr. DeJoie Brewer, you were diagnosed with sickle cell disease a little later than Lyric. Lyric was diagnosed at birth. What was the process for you to discovering your diagnosis?
Yeah, I had a very different path from Lyric. So when I was born, newborn screening was not law. I actually worked and was part of the team that really worked on some of that initiative in order to make it law for all the states. So my story is more of walks like a duck, looks like a duck, walks like a duck, must be a duck. And it's really where you're at and people that can see you and know your symptoms and recognize it. So for my entire life, I was misdiagnosed. I did get sick when I was young, went to the hospital. No one can figure out what I had. And when I went to med school, which is at University of Pennsylvania, I was right next to CHOP Hospital. And my first crisis and the first episode that I had there, the director of our med program just looked at me and said, all your symptoms sound like sickle cell disease, like literally, just by hearing what I was going through. Mind you, this is 20 something years into my life. So I was walked over to CHOP, and in minutes, literally, which felt like minutes because I was anxious as ever, the diagnosis was made, and that began my journey with sickle cell disease. And it has definitely progressed. It shifted my life. Once I got diagnosed, then my brother got diagnosed. And we had a very steep learning curve. We learned everything we needed to learn. My family wrapped their arms around us. The community at CHOP and Penn wrapped their arms around me. And I just really digested everything that I could to be able to understand the process and what was going on with my body. Then as far as blood transfusions go, I didn't start getting blood transfusions actually until a little later in life. And mine's now has become continuous because I rely on blood transfusions for the past 5 years. I get 6 units every 3 to 4 weeks. And if I don't, I'm literally in crisis every 2 weeks because the production, my percentage of sickle cells is so high that we have to continue long-term blood transfusions as my primary mode of therapy. So, and again, the same things that Lyric had said, the typing, the matching, getting your blood work done. I actually have to split my process into 2 days because it actually is quite time consuming. And I really want our audience to also appreciate that the time that it takes to recover, and this is something I share with colleagues and teams and the like, is not overnight. I mean, we get these blood products and yes, they save our lives, but there's this adjustment that our bodies then have to make in order to maximize the new blood that we have and really level and settle our bodies out. And sometimes it can take 2 to 3, even a week before we feel like ourselves again. But the opportunity that it provides us to live well and not be in crisis every other day is just life-changing. And we are, thankful for all the individuals. I mean, when I say it saves my life, it is not an understatement that I don't know where I'd be if it weren't for all the donations that come in.
Wow, Dr. DeJoie Brewer, for these blood donors who are tuned in and others, you have really just touched our hearts there. And also, too, you've pointed out just disparities associated with sickle cell disease over time, just in your late diagnosis,
Yeah.
but also too, you hit on something as well, dispelling the misconception of the recovery for receiving a blood transfusion. You're right. I think a lot of people feel like, oh, it saves your life, and then just all of a
Yeah.
sudden you're just a miracle, and
Yeah.
you're feeling 100%. But it's a process. It's like if you have a loved one who's having a surgical procedure, there's a time of recovery. So
Yeah.
thank you so much for explaining that, because I think that helps to humanize the process of what our warriors go through, who are managing school, who are managing work, who are managing day to day. And that's what this conversation is really all about. So if you're just joining us, we're speaking with a panel of sickle cell warriors, advocates, and medical experts who are answering questions related to sickle cell disease and addressing a number of common misconceptions as it relates to its impact on the Black community. And we encourage you to place your questions and your comments in the chat so that these ladies can respond during our Q&A portion. Dr. Scott,
Yes, 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 yes.
we're so excited to have you here. You're a pharmacist who also has a son with sickle cell disease, and you know firsthand, most patients with sickle cell disease experience chronic pain and require pain meds to treat it. Now, I've read where studies have shown that patients who are Black and who may have a broken bone or physical injury are often given less pain meds than those who are white or are given no pain meds at all. Is this typically the case for patients with sickle cell disease who are Black and whose source of pain may not be visible as a broken bone?
Unfortunately, Tiffany, that is very true. In 2023, as far as we are advanced in medicine and healthcare, that is still a huge health disparity that minority populations and African Americans deal with on a day to day basis. And people who have sickle cell disease are no exception to the rule. So, unfortunately, yes, that is true.
How should the pain of sickle cell warriors then be addressed in the ER? You said this is still happening in 2023. I can't imagine if I have a physical injury where I need to be triaged, I need to be seen, that I'm not getting, proper pain meds because of my race or ethnicity. But for someone with sickle cell who you may not be able to see the outward manifestations, but they're in pain, how should the pain of sickle cell warriors be addressed when they come to the emergency room?
First and foremost, I would encourage all emergency rooms to adopt and start using nationally published guidelines for the management of sickle cell pain. The ASH, the American Society of Hematology, has created specific guidelines that designate how sickle cell pain is to be treated. You alluded to when people come into the ER that they are triaged. Well, if you look at the guidelines, sickle cell pain is triaged at a level 2. When you look at triage levels, 1 being the most severe and going up to 5, well, if sickle cell disease is categorized as a triage level 2, that lets you know that it is extreme emergency and urgency, that people that report with sickle cell pain need to be managed immediately, basically. And when the healthcare providers go to manage that pain, opioids are the mainstay of treatment. Not an NSAID, not Tylenol, not just pain, not just IV fluids. Opioids are recommended in the guidelines to be given via IV to a patient that reports with a vaso-occlusive episode. In addition to that, that time frame that is required is within 1 hour. So within 1 hour of that time for that person entering the facility, they should have pain medication started. And that's not the end. They need to be reassessed every 30 minutes until that patient receives pain relief. And if they don't receive pain relief, then there is a dose adjustment that is required. So it is not rocket science. All you have to do is follow the guidelines that have already been published to help adequately control the pain of someone who has sickle cell disease.
Very important guidance and information there, Dr. Scott. Thank you so much for sharing this. This is published guidance by ASH, I believe you
Yeah,
said earlier.
ASH, the
Um,
American Society of Hematology, the emergency physicians, they have guidelines for the
I
management
just
that
gonna
were
add that.
created. Yeah,
Yes,
that were created in combination with ASH.
yes.
So the information is there.
So I think, Dr. Deja Brewer, both of us are going to have conversation about this, but it's a larger problem in medicine that starts with medical education as to why the healthcare needs of the Black population and underrepresented and marginalized populations are not treated in the same way with the same kind of respect as when a white individual reports to the emergency room. As both Dr. Scott and Dr. Deja Brewer has said, there are guidelines which are certainly not followed, but that's because during medical school training and residency training, there is very little focus on the healthcare needs um, of marginalized and underserved populations. And with sickle cell disease being the most common inherited disease in this country, it requires being spotlighted, yet it's not. And it's related to the structural racism and bias that's built into training in medical schools.
Right.
I
And to build on the comment that Dr. Miller just made, I think when I remember and recall my medical school training, I think we got an hour, right? An hour that included all hemoglobinopathies, of which a portion of that was sickle cell disease. So in my institution, because we had the experts there, we had extra tutelage and learning. But I do, the one thing that's a good thing is that there are more and more patient panels and there's more attention being given because everyone in the medical community has recognized how much we are feeling this community and how the onus is upon us to take the charge to learn more in order to provide more compassionate and more complete comprehensive care.
So knowing that this is kind of a work in progress, right, to spread broader awareness both in the healthcare treatment portion, but also too in the advocacy space of this. Dr. Scott, what are ways that patient and family members can truly advocate for the best care possible and avoid being denied pain relief?
I would suggest that families, one, develop relationships with their healthcare provider, because it's how they say you get more bees you may not get the progress that you need or the healthcare that you need for that matter. So, in building a relationship with your healthcare team, there would also come about the development of your and with you everywhere you go. If you have to shrink it down to about the size of an ID, I would say to put those main points and what works for you, take that with you when you go to whatever healthcare institution that you go to, especially if you may end up going to a place where you don't know the people or you've never been there before. At least if you have that information with you, that gives that particular healthcare team a place to start, and it has some identification provider is. So if they really don't know, they can actually follow up, contact that provider, and get more detailed information if necessary. So I would suggest getting your pain management or ID.
Okay, and Dr. Scott, I think you may have gone out on my end. I want to make sure that the audience heard that correctly. You're suggesting that patients carry a pain management card and
Yeah, your pain
ID.
management plan, right? Your
Okay,
pain
pain
management
management
plan
plan.
that is developed with you and your healthcare provider. Typically, it would be your hematologist, or if you're going to a pain management specialist, that person would help you to develop your pain management plan. And that's something that needs to be with you at all times, because sickle cell is not predictable and sickle cell pain episodes are not predictable. You just need to have that information at the ready so it can be most useful and decrease your wait time for receiving appropriate pain management.
That's great guidance. Thank you so much for sharing that, Dr. Scott.
Tiffany,
Dr.
I'm going to add
DeJoy
one more
Brewer.
thing to what Dr. Scott said. And Dr. Scott and I work together a lot. Some things that sometimes what we talk about also is identifying a champion, someone who
Yeah.
can be kind of a co-advocate for you, who may know that hospital, know the system, or someone on your medical team that you can access on a phone, or your nonprofit organization. And I do know, because I've worked in some of those environments and partnered with patients, that a lot of times that helps, because you can get, to put it simply, you get past the noise and get to the work that needs to be done in order to save the life of the person that just walked into your ED, not willingly. Trust me, most warriors do not want to walk into that ED, but we have no other options. The standard of care in an emergency situation has not changed in 100 years. So I would definitely say, if you can identify a champion, they can be magical and transformative in the care that you receive in an emergency room.
I love that. And I can attest, I saw a amazing example of that just about a month ago. So I'm so glad that you mentioned having those champions. I saw where our organization was able to step up and support a warrior with the local team through a medical officer with the Red Cross. And we were able to support that patient, and it just really reminded us this is the life-changing, life-saving work that we do, and this is why we are here, and that's why we are here tonight. So Dr. DeJoy Brewer, disparities in healthcare have been on the national agenda since the 90s. We were talking about the 90s earlier, right? But yet bias and negative stereotypes when it comes to race are still at work. That's what keeps coming back up in our conversation that we're having here tonight. Is bias impacting the way doctors are trained to recognize and treat sickle cell disease?
So unfortunately, the answer to that is yes, yes, and yes. I think, all ends of the equation have biases, but whether it's the physician, the nurses, the ancillary care teams, and as unfortunate as it is, because, bias is learned and taught. So in a sense, taught in that it's passed on. So you have teams and individuals that are trained, and then adopt the perspective and viewpoints of the individuals that either train them, or one experience or one patient that they witnessed. And all of a sudden they have this thought in their mind that supersedes, right, the care that they're supposed to be giving. We all have internal biases and obvious biases. And the challenge for every healthcare provider is to take the patient at face value. You want to believe what they're telling you at the door and treat with the training and the knowledge that you've been given, and put those questions aside. I can remember many times, and it's unfortunate, in one of the hospitals, the hospital that I did my residency, where it was a matter of the team leaving individuals in the ED and wondering whether they were in the actual pain that they are, misunderstanding and misinterpreting what we have as coping skills. And I like how one physician said it the best. We've taught these individuals how to have coping skills, right? And how to deal with their pains. But because they may be either talking on the phone or listening to music or trying to be calm within that process, then they're misunderstood. And then there's a lot of also miseducation. What I find is that a lot of providers still think of sickle cell disease as just a red blood cell disease. It's just a molecular disorder. And they're not thinking of the sickle cell disease in its entirety, which would be the biopsychosocial model. When you think of the incident with the cells, what's happening with the pain, what's happening with the acute, the chronic pain, the neuropsychosocial, and the socio-environmental factors. So it is definitely an environment that is laced with bias, but bias can be unlearned. And that is the fundamental key. And it requires one individual at a time. I mean, even myself as a patient, when I go in with the biases of the unfortunate incidences that have happened to me. But I try to be the bigger person and say that was someone who didn't know. And hopefully when I walk through the door, it'll be someone who does know and is aware. And all health providers owe the same to every single patient that comes through their door that has sickle cell disease. So One person at a time, hopefully, we'll be able to knock down these biases and get better care for our warriors.
If you're tuned into this National Minority Health Summit tonight, I want you to put in the comments, if you can and you're able, bias can be unlearned.
Absolutely.
Bias can be unlearned, because bias is something that we all have, but it's something that can be unlearned so that we can make life not only better for ourselves, but others around us. You said so many amazing things that I want to kind of unpack just a little bit. Dr. DeJoy Brewer, you can go, and we love it when you go. So I just want to unpack just a little bit there. My first question I want to ask you, just in unpacking, is how can we increase cultural competency in this area of healthcare treatment?
That's a great question. I think the first is to allow yourself to be in an environment that you can be educated. I think we all need to be re-educated. We all have to go back and get recertified for so many things. We learn the basics, but when you're dealing with a disease that you don't know, in a culture that's not your own, with individuals that you might not identify with, as a provider, it falls upon you to then get more culturally aware, right? And there are training seminars, there are individuals that you can speak to, there are webinars that are constantly going on, there are organizations within the sickle cell community, a couple that are listening this evening, that will provide that cultural background and the knowledge for you. So you don't know what you don't know, but you are responsible for learning those things. So I would say, first, be open and recognize that you don't know. That's number one. Two, put yourself in educational environments in order to learn. And the other is expose yourself to individuals when they're in your presence that have this disease process, and really listen. I think as providers, with those biases, we go in and we have a playbook in our minds already. So we're not most of the time even listening to what the individual is actually telling us. And we as individuals can learn so much by actively listening first. It's about taking a pause, listening and absorbing what the individual is telling you, and then acting. I think we reverse those roles a lot. And by then, the biases that we inherently have supersede the new knowledge that we can get. But every interaction is an opportunity to learn more and then do better the next time. So that if you're not exposed to those opportunities, go find them. There are nursing seminars. I just attended 2 or 3 that had amazing webinars and information on cultural sensitivity and unbiased training. So I think those are some essential steps where people can start.
So let me just add that the work of becoming culturally competent and dealing with our own personal biases is intentional work that you have to devote yourself to. As already been mentioned, there's lots of seminars out there, there's books to read, there's journal articles, there's training, but if you are not devoted to wanting to address your personal biases so that literally you can be better, you can be more understanding, you can be more present for patients and individuals that you are serving, because doctors serve patients. Right. If you're not intentional, we will continue to have the healthcare system that we have today. And so everyone has to hold ourselves and each other accountable for doing this work of becoming culturally competent.
That's good. That's good. We're still unpacking this conversation a bit, and it's so appropriate because this is National Minority Health Month, where we are addressing disparities within our healthcare system that disproportionately impacts underserved communities. And so, Dr. DeJoy Brewer, you went here earlier, and you talked about how some patients with sickle cell disease have been taught to train themselves to be calm in medical settings, to not react openly to pain that they may be experiencing. Although, inside that may be another situation. They may be scared inside. They may be upset and just in excruciating pain, but many of them have managed to train themselves. Are these moments of appearing calm ultimately helpful or harmful for patients?
It's a double-edged sword. So for the patient, because when you're in pain and in an acute crisis, if you allow the stress to build, it becomes a positive loop. So when you get more anxious and get more stressed out for that individual, that can augment the pain, can accentuate it, and it can actually drive the crisis to levels that are even more difficult to manage. So it is so important for the warrior to be able to master those techniques in order to almost keep themselves as close to a healing format as possible. In other words, a sickle cell crisis gone bad can be extremely ugly. We don't even want to talk about what that can end up in. So we always instruct our warriors to try to do everything they can, treat it early, go in and take the meds that you need, do all the steps required in order to have optimal management. But then on the flip side, because and some of these techniques, and it's historical, when you look at the history of sickle cell disease and how it was managed back during the slave trade, individuals were punished for having pain. So this goes way back, where we would just camouflage the pain that we have and still do the work that needs to be done. But an individual that doesn't understand the intensity of the pain and the crisis, and I want to be clear that a crisis includes so many more things than just pain, but we are talking about that because that is the hallmark that you see a patient go through, that sometimes they're punished for that, for the techniques that they're using, because then the interpretation is, well, they can't be in as much pain as they are. And what I tell my colleagues and other teams is, first of all, this person has been dealing with this pain for their entire life. You have no idea what they're actually going through. And you're using your own measure to measure them, which is not what you're supposed to be doing as a provider. You're supposed to be taking what they're doing at face value. And then the other is, there is this association and assumption that it can't be because of whatever the list is, XYZ. They're having a conversation, they're screaming to the top of their lung. They're not screaming to the top of their lung. They're sleeping. That's another very big misconception. Oh, they're falling asleep, so they must not be in pain. And when you look at the texts and medicine and all the studies, it says the complete opposite. So these individuals have literally had to train themselves over time because of either lack of care, because of lack of efficacy of medication, because of lack of options for therapy. It's not by choice. I'd love to run into an ED and say, treat me now, and scream. But neither behavior will get me more immediate care. So that's why I say it's a double-edged sword. We're using things that we've had to use and have been taught to use in order to preserve ourselves. But because the other, meaning the other person who is looking in, can't associate us and not taking the time to really understand and be compassionate and empathetic, then we're judged and the treatment goes in the opposite direction. So it's almost damned if you do and damned if you don't. But I will continue to do, because I won't let my crisis go out of control because of their ignorance. So there's so much to talk about, but that's my short, kind of medium answer to the question.
Yes, and I would just like to add to the point that Dr. Brewer stated about, healthcare professionals believing that, if you're falling asleep, medication that they prescribed must be working, you must be more comfortable, and you must not be in that much pain anymore. But as a person with sickle cell disease, you have to also think of it at the perspective of, you don't know how long this person has been in pain. So just because they're falling asleep now, what if they haven't been asleep in the past day, or they had trouble going to sleep the night before, the last 2 nights before. So it's almost like you should appreciate, yes, the fact that they were able to get an instance of rest, but again, you cannot use that to measure the amount of pain that they are in, the amount of pain that they might continue to be in, or use that as a way to decide to scale back on the medication that they have in their care plan, or the amount of medication that you may or may not feel comfortable prescribing them, because just from a lot of the experiences that I've had, and with myself and from others who have sickle cell disease, a lot of us wake up in pain every day, and we do not have to go to the emergency room unless it is really, really excruciating pain. And to advocate for yourself on top of that and explain why an illness that has been around for decades requires this much care and this much attentiveness is very difficult. It's a very, humiliating experience as well, because it just makes you feel like, why am I here? And it could be a very scary feeling, because it's like, I'm coming here because I'm trying to keep myself safe, because so many other things can happen as a result of a sickle cell crisis, whether it be organ failure or, just fevers. Just is a long list of other complications that can occur with a sickle cell crisis. And you want to feel like, as a patient, I came here to keep myself safe, but I'm coming here and you're trying to give me an ibuprofen or a Tylenol. It's like, it's almost as if I was better off staying at home to die, as opposed to being in a medical professional's face who you want to trust and you think who has this knowledge and this training to take care of you, but their bias is keeping them from connecting with you as a person, as an individual, and as a human being. So I just really want to encourage healthcare professionals out there to treat patients with sickle cell disease as you would treat someone, a part of your family, or one of your loved ones, because as I said before, that can be a very discouraging feeling, and that is a feeling that I would wish on no one.
Thank you so much for sharing that. Um, you all are are having such rich conversation on this topic, and I'm even seeing comments where someone just said, "Woo, lyric." That is so true. Someone just Jean Marc de Joie just said church, and we know that's like amen. Speak, preach, teach. And I also saw where Radiance mentioned too in the comments about, unfortunately, many patients who have sickle cell are just viewed as drug seeking. And so, Dr. Scott, fact or fiction, there are no characteristic findings that define the severity of a pain episode. Is that fact or fiction?
I will say that's a double-edged sword. One, there are no lab findings that indicate the severity of a pain episode, because each person's level of pain or what their pain tolerance level is different. So there are no laboratory markers that you can look at that will definitively say this person is a level 10 as far as their pain scale goes. Now, when you go and look at your traditional markers, when you look at hemolysis rates, when you look at blood pressure, when you look at heart rate, those things can be indicative that something may be going on in that person's body, but that is not a sole factor that will tell you the severity of what a person's pain scale or pain rating is at that particular time. It's so important to listen to the patient, because the patient is going to give you a report of what their typical pain episodes look like. You have to take the patient at their word in this instance, because they've been dealing with sickle cell disease their entire life, where you may just now be looking at them, or you just may now be encountering this at this point in time because this person came in while on your shift. You may not have seen it since you saw it in medical school for that 1 hour or the brief period of time that you did get introduced to it. So you've got a person with a lifetime of experience that can really help guide you in this space, not necessarily looking at laboratory markers or going by exactly what you learned in medical school to the T to differentiate a person who's really having a sickle cell pain episode versus someone who's not.
So, with that said, would you say it's fact or fiction that the pain assessment of a patient with sickle cell must be accepted?
I would say that is fact. The pain assessment that the patient reports to you. I don't want to know about your 1 to 10. What is 1 to 10 for you and your level may not be what I think of as what's 1 to 10 in terms of severity. So the pain assessment that the patient reports to you, I would say, yes, that is fact. That is something for you to believe. And I want to talk about this just a little bit because I know we're in this opioid crisis and there's a lot of creating a person who is addicted to drugs or feeding into some type of a that number was not leading.
So unfortunately, I think
Uh-oh.
Dr. Scott, I'm sorry. It seems like you were frozen a little bit there. Could you repeat what you just said?
Yes, I want to talk about the opioid crisis because I know we're walking the opioid epidemic. Did you hear me on that part?
Yes, that we
Okay.
have an opioid crisis and epidemic. I did not hear what you said after that.
It is not being led by patients with sickle cell disease.
That's right.
So, with that in mind, when a patient comes into the ER or they're reporting for a vaso-occlusive episode, then you can take that patient's account of what they're experiencing to be fact and treat them according to our.
Thank you so much for emphasizing that point because we definitely need to be aware of that. We need to know that we can't measure the two the same. That one is a very different situation when we're talking about patients with sickle cell disease. Dr. Miller, according to some studies, someone living with sickle cell disease may visit the ER about 3 times a year and may need a blood transfusion. If there is a cure for sickle cell disease, then why do many patients still need blood transfusions?
Um, uh, there is, at this point in time, there is a single treatment that is curative for sickle cell disease, and that's a stem cell transplant or a bone marrow transplant. And not every patient that has sickle cell disease is a candidate for stem cell transplant or bone marrow transplant. There are some treatment modalities that are under research right now that look very, very promising in terms of being a cure for sickle cell disease. But currently, blood transfusion, which is the first, besides pain medication first, is the second best, I guess, second treatment that individuals undergo to treat their pain crises and to prevent complications of sickle cell disease. So while we understand, and there are some new medications on the market as well, before 2017, the only drug that was approved by the FDA to treat sickle cell disease was a drug that's known as hydroxyurea. But since 2017, about 4 drugs have come on the market to treat sickle cell disease. So there are some medical treatments. Again, the only cure is stem cell or bone marrow transplantation. There are some experimental treatments that look very promising, but only at this point, only blood transfusion provides the oxygen carrying blood cells that patients with sickle cell disease need to decrease the vaso-occlusive or pain crisis.
And Dr. Miller, what can happen to patients with sickle cell disease if there is a blood shortage?
If there is a blood shortage, as Lyric and Dr. Dejoie Brewer have indicated, they may have to wait days to get adequate amounts of blood to treat their symptoms, their complications. And the longer a patient is suffering from complications, the more damage is done to their tissues and done to their body. So the sooner that they can find compatible units of blood, and again, in many cases, they need multiple units of blood, not just one or two units. Those, like both like Lyric and Dr. Dijois Brewer, they are on what is called an apheresis exchange protocol, meaning every 3 to 4 weeks, they have to have basically over 50% of their blood in their bodies removed and then infused with normal red blood cells, and that treats the complications and the pain crisis. So it's absolutely critical for multiple units of blood to be available for these, what is called an exchange transfusion. And again, we are in constant need of blood donations by individuals of African descent to ensure that we have adequate amounts of blood on the shelf for the treatment of patients with sickle cell disease. And again, I'm going to go back to that statistic. 1 in 3 blood donors, African American blood donors, is a match for a patient with sickle cell disease. So the need is constant.
Wow. Lyric, you've been sharing so much of your journey with us tonight. Sickle cell disease clearly is a largely misunderstood disease, and you've recently teamed up with WebMD to help create a community of resources and support to sickle cell warriors and others who want to help advocate. How does community help validate the significance of sickle cell warriors who might sometimes be discouraged subconsciously in our society?
Well, for me personally, I think it's always been helpful to connect with other warriors just because it allowed me to have a sense of security and just the validation that I know that I wasn't the only person going through these experiences. When I was younger, the hospital that I was a patient at, the children's hospital I was a patient at, actually used to send their patients to sickle cell camp, and it was there that I met other patients with sickle cell disease for the first time. I had no one else in my family who has sickle cell disease. I came across some people who had the trait from time to time, but that is not the same as a person, who has the full disease. So when I was able to go to these camps and see other children, who had to take as much medication as myself, or required blood transfusions as well, or needed to be inside of heated pools, just all the different things that I had to do to try to minimize my symptoms from sickle cell disease, have to do the same thing. It definitely just made me feel like I could confide in them, and that we could encourage each other. And so now, as an adult, and unfortunately witnessing some of those patients that I met back then pass away from complications with sickle cell disease, that just inspires me even more to do the work within myself to try to create those types of communities for other patients like myself who may not have had the experience of going away to sickle cell camp and meeting people, that were in their age group that had the disease, from children younger than me to children the same age as me to even the counselors who would attend the camp having the disease themselves. And so I just hope that what I'm doing with WebMD, which is writing articles for them, just explaining all of the different experiences that I've had with, just being a student living with sickle cell disease, or being a family member living with sickle cell disease, or traveling with sickle cell disease. I hope that by me writing articles and sharing those experiences, as well as getting other people to join the um, Facebook group, will help people, like I said, just remain inspired and know that it is something that they live with, and it is not something that lives with them. So they can still, set goals and still do things that those around them do, but they just may have to take another avenue. And so, I'm just very appreciative of the support I get from my family and my friends, but I'm also aware that everybody might not have um those supportive systems. So I'm trying to create those by people who they may not interact with or come across on a daily basis.
That's amazing. And we'll make sure we're going to include that link to that new Facebook group with WebMD that you will be helping to provide fresh content and amazing perspective into the comments at some time. So you all look out for that. We have to wrap really soon. So make sure if you have any questions for the panel that you drop those in the comments. We want to be able to address those. Dr. DeJoie, I have to ask you this. Is there a correlation between how a patient views themselves and how they are treated and seen with their ability to heal within their own body?
Great question. I do actually want to make a comment, though, related to what Dr. Miller said, and a comment that came in the box about a patient who had to wait a month for their blood. And this is so important that I'd rather speak on this. And if we have time, I can totally talk about the mind-body experience. But technically, we are still considered to be in the midst of a blood crisis. And there are many, many patients who have been asked to either delay whether they can wait another week, or they've pushed out their timeline to twice as much. And I've heard healthcare providers actually say things that they didn't know that I was listening, and say, do they really need that many transfusions? And this is the person's life. This is their quality of life. And you are, in a sense, saying that they should stay in pain or discomfort or at mal-ease for an extra week or two in order to change their life-saving cadence because someone else might need a blood supply or need a blood transfusion, where the warrior is extremely deserving of that. And no illness should have to wait longer than they need to. But I think the level of severity and acuity that is attached with a sickle cell crisis and a vaso-occlusive crisis, and the fact that if it's not controlled well, can end in death. And you never know which one will culminate to that point. That if there is a way to treat that individual and improve their quality of life and keep them away from that type of incident, we as healthcare providers need to do everything possible in order to make that happen. And no warrior should have to wait any longer than necessarily. We are not supposed to be living in a punitive healthcare system. So I just wanted to speak to that point, and I know we've all elevated that, but it's very important, and why we're having this conversation to one, have blood donations, but also to give individuals the proper care that they need at the time that they need it, in the way that they deserve it. So
for sure. And thank you for elevating that in the conversation as well. I think it ties in kind of to the question about mind and body. So based on the type of treatment or how they're being viewed as patients, how important is it for warriors to consider their mental health, and what are ways that they can do that to make sure that they help heal within themselves while they're going through some of these challenges?
Absolutely. As part of the Sickle Cell Mental Health and Wellness Initiative, that is such an important topic for us, because we know that the health of an individual is really dependent on how well they are. What tenets do they have that keep them healthy and complete on a day-to-day basis? What is the macro picture? And part of that macro picture as an individual that lives with a chronic disease is knowing self and being strong with their identity, and knowing that they can, in spite of that, it's not that the disease has us. A lot of times we say that it's not that I'm sickle cell disease and then Marjorie. I'm Marjorie DeJoie first and then sickle cell disease. So as much as we can do things to elevate that mental health and that wellness, which speaks to whether we are breathing correctly, whether we have the right nutrition, whether we have things that we can stay centered, whether we are connected and have community. There's so many points that can elevate that. And what we are often struck with is that when someone is diagnosed with sickle cell disease, it's often given with this language of condolence. It's often given within this envelope of, we are so sorry to have to tell you this. But what I have experienced is that in the right hands, I was told that you can do anything you put your mind to. You just happen to have sickle cell disease. And you know what? We're going to help you manage that and build some skills within you and provide you tools so that you can stay mentally centered and focused. So there's definitely a pathway for that. And we are hoping that the medical community envelops and encompasses that type of protocol within that biopsychosocial. And that's where the treatment is. You see, when I go to the hospital, when individuals go to the hospital, those are just the band-aids. Those are just to bridge the gap and get us through. The real work is, how do we build that base of health, wellness, and mental soundness for our warriors so that they have this self-belief, like Lyric has spoken to. Like, I'm not going to let this crisis get in the way. We're going to make this happen. And that's what part of this conversation is.
Mhm.
Thank you so much, Dr. Dujois Brewer. Dr. Scott, your foundation, Breaking the Sickle Cell Cycle Foundation, you've been able to help raise awareness through education and services, but you also host blood drives with the Red Cross to support patients with sickle cell. And I know Dr. Miller shared with us earlier the 3% of donors who are Black, just within the American Red Cross donor base, which we're working to increase. But I have to ask you, because you're hosting these blood drives in the community, fact or fiction, do Black people not give blood?
That is fiction. Black people do give blood. I would not continue to partner with community organizations, different universities, and churches for the lack thereof. So, yes, Black people do give blood, and that's one of the ways in which we are able to get people out, is partnering with places people already go. We partner a lot with universities. A lot of students are at universities. That's a prime location. And I know the Red Cross has that HBCU initiative in getting more African American donors in. We partner with a lot of Greek organizations and their alumni organizations as well to get more minority donors in. We partner with our local health department by participating in events that they are already hosting. So we get in where we fit in. We don't have to recreate the wheel. We show up right where people are. And that's one of the things that I pride our organization on, is meeting people where they are. We don't sit on the sidelines and wait for people to come to us. We go to them and provide our services.
I love that. As our audience member said, preach and church and all that. Dr. Miller, we're getting ready to close out, but for those who may be unfamiliar with the process of donating blood, can you share the steps with us?
Yes. So the first thing that we encourage people to do, you have to be feeling, the first thing is have to be feeling healthy and well on the day of donation. And you have to weigh at least 110 pounds. For most people in this country, that is not a problem. So you have to be feeling healthy and well, 110 pounds. And then make an appointment. That's the third thing. You have to make an appointment. And then when you present to the collection site, get your blood pressure taken, your pulse taken, and we measure your hemoglobin. And then we take the unit of blood. It literally takes about an hour. So if you look at using an hour of your time very effectively to help save someone's life versus some other activities that you might participate in, donating blood can be one of the most important things you do in your life to support the transfusion needs of patients with sickle cell disease, and just to support other community members. And that is and blood donation is one of the ways that we as individuals of the Black community can help address the health disparities and health inequities in relationship to this population of patients that have sickle cell disease.
Thank you so much, Dr. Miller, for all you do to support the mission of the Red Cross. Thank you, blackdoctor.org, for partnering with us to host this awesome discussion and summit. Dr. Dujois Brewer, Lyrica, and Dr. Scott, as always, it's a pleasure to soak up your insight and wisdom. I know there are those who would like to know where they can learn more about you and your work. So I'll give you a quick opportunity to share any websites or social page info or handles with our audience members tonight.
So I'll go real quick. The email that people can use to reach me is madfitbody@gmail.com. That's madfitbody@gmail.com. And my Facebook handle is Brooklyn Contessa. We also have the Sickle Cell Mental Health and Wellness Facebook. I can be found just about anywhere. Willing to connect.
And I'll go next. You can find me on all social media channels. It's at BRKBSS Cycle. That's Facebook, Instagram, and Twitter, same handle. And it's Breaking the Sickle Cell Cycle. So it's B as in boy.
Thank you so much, Dr. Scott. And Lyric, I'm sorry.
Yes.
You an A to your name, Lyric.
Yes. So I can be found on Facebook at my name, which is Lyric Porter. And then my email is also Lyric LYRICA Porter PORTER @gmail.com. And if anybody, like I said, is interested in joining the group, they can reach out to me and I can provide them with the link. And I'm just excited for this opportunity.
Awesome. We're excited to have you all. And there was a quick question from Etta. Dr. Miller, I want to turn to you. She wants to know, how do you find out your blood type? If you could share that really quickly.
Mm-hmm. Whenever you donate blood, every time a person donates a unit of blood, we reconfirm their blood type. So certainly when you donate blood, we find out your blood, we identify your blood type. And I encourage everyone to go to redcrossblood.org, find out as much as there's lots of information on there about blood donating, specifically in relationship to African Americans and people of African descent. And I also encourage you to download, it's a Red Cross blood donor app. And in that app, when you donate a unit of blood, all your information is in that app, your blood type, as well as we monitor individuals' blood pressure, as well as your hemoglobin. So you can find out all that information by donating blood and downloading the app. And in terms of my contact information, it's really simple. It's my first name, YVETTE.Miller@redcrossblood.org. And I look forward to all the questions that I think they'll probably be coming my way. So I appreciate it. And thank you so much. Women of power and privilege here, sharing this space together. And I already saw in the chat, somebody said we need another segment. We need a round 2 on this. So trust me, we will have this again.
All right, blackdoctor.org. Thank you so much again for hosting us. We'll be in touch about a part 2, perhaps. And those of you watching, know that patients with sickle cell disease, like all of us, deserve excellent health care, peer support, and less stress. The more we learn about the facts of sickle cell, the more we can help our loved ones and those battling it. With blood transfusions remaining one of the most critical treatments for patients with sickle cell, you can help ensure our warriors don't have to worry about having the blood donations they need to thrive by simply rolling up a sleeve to give blood or hosting a blood drive in your community. Dr. Miller and I are both proud African Americans who roll up our sleeve and donate blood, and we encourage you to join us. To learn more, visit redcrossblood.org/ourblood or call 1-800-RED-CROSS. Thank you so much for joining us, and take care.